Hello, welcome to join our MCS and COXO free public webinar. This is Ahmed hosting this live broadcast. This time we are honored to have invited Dr. Zivile Grabliauskiene from Lithuania to share with us her topic, Rotopics from Radiology to Biology in English language. And now let me introduce Dr. Zivile. She have a PhD DDS Associated Professor, Senior Lecturer, Lithuania University of Health and Science, Department of Dental and Oral Pathology. And now let me introduce to you MCS Company Dental Department. Mrs. Sinai for dental supplies were found in 2009. We are agent for COXO in Egypt since 2010, sole agent for COXO handpiece since 2019. We have also the Endo motor lines, C-Smart 1 and C-Smart Pro, C-Smart Mini AP and C-Smart Mini Eco. And also the last edition from COXO, the C-Smart 1 Pilot. Suku Night files, SC Pro and Suku Glide Bus S1 reciprocating files and SC Pro Mini. And the obturation system, which in C-Fill, Pack 1 and C-Fill Mini. And now, with all COXO handpiece and dental electric motor, C-Puma, and even the new C-Puma Master, and implant motor, C-Sailor and C-Sailor Pro, Light Cure line, like Delhi, and Light Cure Nano. Also the bleaching line, C-Bright, mobile device and unit-mounted device. Dental microscope, C-Clear 2. Thank you. That was about MCS dental sector. And now, let me tell you about our certificate. Every time during our COXO free public webinar, we will prepare a certificate for those who join our courses, which will be part of the qualifications of the dentist career. And now let me introduce how to get our certificate. As you can see, the first step will be by follow and like COXO Facebook page. And second step, by leaving your comment or question below the live video. At the end of the live, we will share the form link to the comment below the live video. Please open the link and fill the form and submit to apply for the certificate. We will do the above mentioned 3 steps. All will be done, and through 5 days, you will receive PDF format certificate in your email. Very important note, the form application can be filled only one time and will be available for only 5 hours after the lecture. 5 hours later, the application channel will be closed. After that time, we will not accept any application. So please fill on the form as soon as possible after webinar. Second note will be the form cannot be modified. So please make sure the information you left are correct. And finally, here is the shape of the certificate you will receive. And now, okay, now I will remind you about the webinar. We are preparing 2 prizes. The first one will be we will give the first prize to the best question. So please leave your questions below the live video. Dr. Zivile will answer your question and she will pick up the best one. The person who raised the best question will get 3 sets of our SC Pro Endo rotary files, and the second prize will be chosen by the lucky draw. You all what you need just to leave your comment on the video during the live, and then you can have the chance to get our special gift. We will make a lucky draw tomorrow on MCS and in our page and COXO Facebook page too. The lucky one also can get 3 sets of our SC Pro Endo files. Okay, now let me welcome Dr. Zivile. Welcome, Doctor.
Hello, everybody.
Okay, now we are ready for to start your lecture, and we are appreciate your precious time to share with us your excellent experience about this lecture.
Okay, thank you very much, Mr. Ahmed, for introducing me. And thank you, COXO Company, for inviting me to have this webinar for you. Actually, I will try to answer your questions. I'm not sure if I will answer. Maybe your questions will be too tricky for me. And I'm not sure, but I will try to do my best. So today my lecture is going to be about the root apics. So from radiology to biology. Let me shortly introduce myself. As you know, I am Professor Zivile Grabliauskiene. I am from Lithuania. It's very small, northeastern European country. Very small but very green. A population of Lithuania is only 2.8 million. So, as I'm used to tell for my friends in Egypt that is only 2.8 million, they are laughing and telling that there's only one part of Cairo. It's a very small part. But my country is very green and many forests and lakes. And we have many buildings of World UNESCO Heritage, very nice downtowns. So you're welcome. Visit my country. Let me do short introduction to my lecture. Why I decided to talk about root apex. This my endo treatment was done maybe 4 years ago, and I was so happy about my high filled lateral canal. And this photo I've sent to one of my colleagues just to show how it's possible to obturate the lateral canals. But I've got a question from him. What about the walking length is not too short? So just I was surprised, and I thought for myself, this is about what I have to talk with my students, my colleagues, the doctors, and my listeners. We know that the distance between the radiographic apex and root canal filling material, even it could be 2 or 3 millimeters from radiographic apex. But if I will raise a question, how many dentists will assess this obturation as a short fill? I think so. Can get an answer, but many of you could think that is too short. The point and an idea of my today lecture to change the way of your thinking, just to change your thinking from radiology to biology. Because if you mention, especially nowadays in social media, the people are crazy about the white lines. They're crazy about white lines, but they are not taking care about biology too much. So today I want to talk with you more about what is inside the root apex. It's not about this nice white lines. Why we have to talk about the root apex, especially apex, not a middle part of the canal, not a coronal part of the canal. Because nowadays we are not talking about 1, 2, or 3, or 4 even canals or 6 canals. Nowadays we're talking about the canal system or a network of a canal. And especially this network is in root apex. These 3 millimeters of apical part are the most dangerous zone in the whole the canal. Because morphologically, it's the most difficult part of the canal. Clinically is a challenge even for experienced dentists. Radiographically, the place which impossible to evaluate on X-ray, and treatment prognosis is the most important part. Here you can see my endodontic treatment, which was done the same maybe 2 or 3 years ago. And that's why always I am doing my all endo treatment steps under the microscope, from access opening to the obturation. So when I made this X-ray, I was shocked about the mess what I got in my palatal canal. And I removed everything from the canal. I did obturation again. And only after some hours I realized that what I got here is my network system, is my canal system. So this is not about one or two canal system, is a network. And this network, it could be seen if you're doing very good irrigation protocol, when you are opening the lateral canals, when you are opening the apical deltas, and after that, if you are doing good obturation and a sealer is going inside all the small canals, lateral canals, or accessory canals. In the beginning of last century, physician and dentist Dr. Meyer Rain introduced a technique for determining canal length and level of obturation. Some years after, Black suggested a measurement control to determine the length of the canal so that overfilling could be prevented. Even at the beginning of 20th century, the dentist knew that this overfilling and over-instrumentation could be prevented. The first endodontic congress was held in the United States in 1953, leading by Dr. Louis Grossman. And they made some statements. And one of the statements that instruments should be confined entirely within the root canal, or root canal filling should terminate at this level rather than at the apical foramen, meaning at this level that is shorter than the apical foramen. If this statement was written more than 70 years ago. So, is a question, a normal question, why there is still debate. Where is the limit for instrumentation obturation? You can see many debates on the social media. They're debating about the limits for this obturation instrumentation. And for me, it's so strange because it's even more than 100 years ago, the dentist knew those limits. So let's go deeply into the root apex. There is a three main zones in the apex. Is the apical foramina with cemento-dentinal junction and apical constriction. So briefly about all these three parts. We have to raise the question, which point could be used for our apical termination? I mean, for instrumentation and obturation too. Could cemento-dental junction be this ideal apical termination point? Yes, it could be, because it's the best place and it's the only one place where the pulp tissue ends and periodontal tissues begins. However, cannot be observed entire all root canal. It could be even in different position on different walls. This position is highly variable. Look, here's a cemento-dentinal junction in one wall, and here's another wall. So how it could be as a termination point that is at totally different distances in the different walls. And the worst thing, that this cemento-dental junction cannot be determined clinically only by histological examination. And distance for this cemento-dental junction could be 1 or even 2 millimeters from apical foramina. However, determined position of cemento-dental junction and use an apical limit is impossible. Biologically, it looks like it's a best point, but we cannot use it in our clinical practice. What about apical foramina? Could apical foramina be an ideal apical termination point? First of all, I want to remind you that the apical foramina is really located at the anatomic apex and no coincident with the apex of a root. So here you can see the apical foramina, here you can see anatomical root apex. And location of this apical foramina is only possible histologically. Even the position of apical foramina is highly variable compared to anatomical apex of the root. This position, it could be even from 0 millimeters until 3-4 millimeters from the anatomical root apex. Some disease as chronic apical periodontitis, inflammatory root resorption can eliminate totally apical foramina. And what I want to remind you that not only the secondary or tertiary dentin we have in our age formation, but the same we have in time continuous cementum deposition. And this cementum deposition, then the same can alter the position of apical foramina. So with the age, the distance from radiographical or anatomical apex to apical foramina is increasing. That is interesting for me because now in our days and new days we are talking many things about the ramification, apical ramification, that we don't have this one foramina, we have 2, 3, or 4 foraminas. That is interesting for me, but I found it that this picture was published in 1907. It means more than 100 years ago the dentists knew about multiple apical foraminas. So even according to literature, 75% of a teeth could have apical ramification. So the apical foramina is not reliable reference points for working length determination. The third point is apical constriction. There is some synonymous as physiological foramen or constriction minor. Question: could be used apical constriction as ideal apical termination point? This is the narrowest part of the canal. Periodontal tissues is the least traumatized by instrumentation to apical constriction. The same continuous cementum deposition can alter the position of apical constriction the same as apical foramina did. Inflammatory root resorption might totally eliminate the apical constriction. So there is the two camps or two teams who are fighting between each other. Could we use the apical constriction as termination point? If you will do your clinic and shaping until apical constriction, it might be risk to leave some infected tissues beyond the apical constriction in this position. So it's some statement from one team, and another statement is from another team that is the same, is based on some researchers, and you can see this is from all time in 80s, that histologically, even if we have a chronic apical periodontitis, the tissues at the apex and apical ramification remains vital and often even uninflamed. You got a point? If we have a refaction, if you have a disease, if we have a chronic apical periodontitis, in some cases here the pulp tissue still could be vital. A variable portion of radicular pulp tissue may be vital and non-infecting. This is a latest study from 2019. And despite necrosis and bacteria establish themselves in the periapical lesion, the instrumentation and obturation should remain at the apical constriction. So in my point of view, we don't have to talk anymore about a termination point because Even, even, it's about apical constriction was written in some paper that was published at the end of 19th century. I don't remember what I found it, but look, even in 80s, they wrote about the apical constriction, that the obturation should end at apical constriction. So again, in most of the studies, is recommended to do your instrumentation obturation exactly at the point of apical constriction. This is a problem that is frequently impossible to know exactly where is the apical foramina and, of course, where is the apical constriction. So, as a normal question, we know that our ideal point is apical constriction, but how to locate this apical constriction if it cannot be located clinically? Third and very old method is tactile sensation. It is interesting that a study published in 1975, it was written that experienced endodontist could detect the apical constriction by tactile sensation in 60% of the cases. Of course, in that days we didn't have a microscope or no loops, nothing, and instruments. We had only manual instruments, no rotary instruments, so the manual sensation was much better. However, the anatomical variation in apical constriction, location, size, tooth type, and age make working length assessment unreliable. Of course, if we'll use a tactile sensation for determining the apical constriction, we will have a questionable success. So another very old method, the same, is moisture and paper point. You know that you're inserting the paper point into the canal, leaving there for a few seconds, removing, and the paper point usually is absorbed or some tissues liquid from periodontal tissues or a blood. So in that case, you have to measure, and here you have your working length. Of course. I don't think so. If you will use only this paper point methods to locate the apical constriction, in that case, can have a questionable success. What about radiography? I think so that in nowadays the world is crazy about, the dentist world is crazy about the CBCT and radiographical images, and in all the cases they're trying to do X-ray. It doesn't mean that it's only diagnostic tool. So question, can we use a conventional radiography or digital radiography to locate the apical constriction? Actually, the accuracy of radiographic locate the apical constriction in front teeth is only 32%. In premolars, 32%, the same, and in molars is dropping until almost 14%. So you have to remember that the files terminating at the radiographic apex in vivo had actually extended beyond the apical foramina in 50% of the cases. So if radiographically we could see that your working length, your instrument, or your gutta-percha cone, it's at exactly at the radiographic position, so usually in 50% of the cases you will have over-instrumentation or over-obturation. This is some simple studies what we are doing with my students on preclinical endodontic course. So it's very easy to see that the apical foramina, as I told, is not exactly at the anatomical end of the root, anatomical apex of the root. It's usually open laterally, and the same you can see if we have an X-ray that is even not so close to radiographic apex. Usually in vivo we have a instrument beyond the apical foramina, and this curvature, the apical curvature, is very hard to see on our 2D dimensional conventional or digital X-ray. Of course, it's better to see in CBCT, but I don't think so that we need to do it on every case. It's just to see the curvature. Just we have to know it. That's all. And the same, I like to do some experimental works, especially on my own teeth. This is my wisdom tooth. This is my wisdom tooth. It was extracted due to caries in the distal contact surface, and I did some investigation. You can see I put it my instruments to the radiographic apex level, and exactly you can clearly to see that the instrument is beyond the apical foramina. So adopting the radiographic apex as a reference point would result, of course, for over instrumentation and after that over obturation. Of course, it's very dependent on the diagnosis what we have. It's a different diagnosis, but we have a vital pulp, or we have a pulp necrosis, or we have a chronic apical periodontitis. And you can read in many articles on even books that if we have vital pulps, so clinical and biological findings shows that in that cases, our instrument could be even 2 or 3 millimeters shorter than radiographic apex. It means that we still that in that place in the apex, we still have a vital, as I told you, non-infected and even non-inflamed pulp tissues. It's a different point when we have a teeth with necrotic pulps. And in that cases, the suggestion is to do instrumentation obturation 0.5 or 1 millimeter shorter than radiographic apex. It's interesting what I found that instrumentation reduced the healing rate of conventional non-surgical retreatment cases and led to development of new apical lesions. So it's not suggested to do over instrumentation in retreatment cases, and especially retreatment cases. Why we do retreatment cases? Because we have a disease, because usually we have a chronic apical periodontitis. So even if we put a clinically working length 1 millimeter short of a radiographic apex, the position could be exactly at the apical constriction of our instrument. Only 22% of anterior teeth, 35% of premolars, and only 11% of premolars. What I want to tell you, of course, we cannot put our instrument till radiographic apex because we know that in 50%, almost 50% of the cases, we'll have over instrumentation and over obturation. But even if we put 1 millimeter shorter than the radiographic apex, the same, it's impossible to evaluate exact position of apical constriction. So radiographic image does not allow observing the position of apical constriction or apical foramina. However, the X-ray is obligatory to have. The preoperative radiograph is essential. Why? Because we have to know anatomy of a root canal system. The number and curvature of roots. Here you can see this the canine of two roots, not two canals. The presence or absence of disease and could be as initial guide to calculate the working length. There is some limitation on conventional and digital radiography when you want to do determination of working length. First of all, it could be distortion or magnification on X-ray. So you have to choose parallel technique if you want to have a normal length of your root, not a semi-angle technique. Another limitation of our 2D system radiographic that the root canal system is superimposed radiographically by some anatomic structures. There's some special anatomic structures in maxilla and another anatomical structures in mandibula, foramen mentale, canalis mandibularis. Another limitation that I think so that the biggest limitation that this our digital radiography or conventional radiography provide a two-dimensional image of a three-dimensional structures. is a clinical cases of one of my friend. He came, it was before Christmas. He came with a swelling, and I did a periapical X-ray, and you can see here radiolucency next to mesia buccal canal. All the canals are nice filled. This is a glass fiber post, and put it a crown. Of course, the endodontic treatment was already, the tooth was already retreated 10 years ago. And when I saw this, I was so didn't want to take a crown or to do retreatment. So we decided to go with the apicosectomy, apical surgery. But somebody told me that I have to do a CBCT scan. And when I did a CBCT scan, I saw the big lesion. It was much bigger than they can see in periapical X-ray. And of course, it was a big fracture of a root. Actually, all the roots were cracked. And you can see the special color of the root. And don't be afraid, the patient is totally healthy. This is called the Russian red root. Russian red root. So why this color is some change like aubergine, eggplant. Another limitation is about interpretation of the X-ray. You have to know how to read the X-ray. I took these results from one study. It was a study about unintentional canal overfilling, and for me was interesting about the agreement level between observers. And the agreement level was only 66% of the cases. It means that even if we have one X-ray, so maybe 50-50 will have or see the different things on that X-ray. So interpretation, the same, is very important. Another limitation is clinical practice. Of course, you have to have more clinical practice. And conclusion from this study is about the influence of clinical experience on the radiographic determination of endodontic working length. In conclusion, they found that the clinical experience after graduation influenced the accuracy of estimating the adjustment needed for correct radiographic working length. So, everybody, that radiography is signs of shadows. And for me, it's so strange that even from periapical X-ray, the dentist can diagnose cracks or something like this, fractures. Is so strange. Sometimes you can see some things that there is no really seen in the X-ray, or to miss some very important things on the X-ray. So, conclusion from radiography, that to locate the apical constriction on radiographic images is impossible. So we can do whatever you want. So how many you want X-rays with the instrument inside the canal will not for you show exactly position of your end of your file. No apical foramina, no apical constriction. So to use the radiographic method for working length determination is unreliable and doesn't have any biological confirmation. So if you ask me, of course, it's very subjective. And another X-ray after obturation always. So I'm skipping one of the X-rays, or with instrument, or with gutta-percha cone. So very rare cases I'm doing sometimes with gutta-percha cone if I have some disagreements in my apex locator or radiographic images or something like this, if I have some feeling that is something wrong. So in that cases, I am doing the X-ray with instruments or with gutta-percha. So if we will rely only on radiographic images to determine the working length or to find the position of apical foramen or apical constriction, in that case, the same, we can have a questionable success of our endo treatment. Using radiographic working length calculation alone led to instrumentation beyond the apical foramen in 56% of the premolars and 33% of the molars. So we need to have some combination methods to determine the working length. It's not enough to have only radiographic images. And this is position of European Society of Endodontology about the guidelines for endodontic treatment and about the determination of working length. And suggestion was to use two methods, is electronic and radiographic. And you can see, I don't think so that they wrote in that order. First of all, electronic, and the second, radiographic. So what is it, electronic working length determination? Of course, everybody are familiar with electronic apex locator. For me, what's interesting that the physically, technically, they found it that there's some differences in the resistance between pulp tissue and periodontal tissue was found in 1918, and the apex locator was constructed only in 1962. Almost 50 years it took to construct the apical locator and introduce into clinical practice. So we know apex locator, everybody using apex locator. For us, as for clinicians, it's very important to know how readings are accurate of this apex locator, and can we trust those readings. If you have a look in many researches done in the past 5 years, you will have the same conclusion from all the studies, that electronic apex locators are clinically acceptable for working length determination. It is no doubt. However, the accuracy of apex locator, I'm not talking about the company's name, I'm not interested in it. 64%, 53%, 64%, and 50% accuracy. So it means that every second case, it could show for us the wrong working length. So according to literature, the accuracy of electronic apex locator to determine the working length or determination for working length is range from 53% to 96%. But actually, in all the studies that is written with a plus minus 0.5 millimeters acceptable range. What does it mean? Acceptable range. It means, as odontologists, we are working in 0.1 millimeters level, 0.2 millimeters levels. For us, is very important. So if it's 0.5 millimeters is acceptable range to determine the position or to determine the working length. So if we'll go 0.5 millimeters from our apical constriction or apical foramina, what we could have? We could have disturbance of periodontal tissues. Our patient will have a postoperative pain. But in another hand, if we will not go to apical constriction 0.5 millimeters, in that case, we could leave infected tissues next to apical constriction. So can we accept this range, 0.5 millimeters? I think so. The scientists need to reconsider that 0.5 millimeter margin of error, and clinically it cannot be accepted. This range. What I want to remind you that if you're doing measurement of working length with apex locator, so you have to remember that the apex locator is determining the location of apical foramina. But for us, we don't care about apical foramina. We care about apical constriction. And we know that there's some distances from apical foramina to apical constriction. And this distance, what we are thinking that is 0.5 millimeters, it's really only in 46% of the cases. It means every second canal has a different distance from apical foramina to apical constriction. And this range, this distance could range from 0.2 even 3.8 millimeters. And distance could increase with age about the cementum deposition. So I want to share with you some distances measured from published in the Dental Research Journal 2016. I was interested about the distance from apical foramina to apical constriction. If you see the mean, it looks like it's normal. It's not even 0.5 millimeters. But here is a range from 0.1 until almost 1, 0.1 until 1. So we don't have average. The average 0.5 is only in 50% of the cases almost. So they use this a single average distance to locate the apical constriction is unreliable and unrealistic. So as you can understand, we don't have any device, any diagnostics, how to determine the position of apical constriction. Of course, we have to rely and we have to use an electronic apex locator. But before you use the apex locator, please always read the instruction of apex locator. Each machine is marked differently and records the apical constriction and apical foramina in different locators on their reader scale. And always calibrate your apex locator. What does it mean, calibrate your apex locator? Always, as told you, all the apex locators showing for you this diameter major or apical foramina. Usually this apical foramina is in red color scale, or the bar is flashing is according to different apex locators. So it's only one but is showing exactly measurement of apical foramina. So usually what I'm doing, if I have, let's say, some necrotic case, I don't like to do anesthesia in all cases. I'm doing anesthesia on vital cases. So if I have a necrotic case, I'm not doing anesthesia. So the patient is the best apex locator ever. Is a natural biological apex locator. So I'm measuring walking length until my apex locator scale is showing the first red bar. So I know that exactly my instrument is at apical foramina. I know that the distance from apical foramina to apical constriction average 0.5. I cannot use another number because I cannot determine clinically position. So I'm removing instrument from the canal. I'm distracting my walking leg 0.5 millimeters, the real 0.5 millimeters, and inserting again into the canal. And I'm checking what bar is blinking or what number is reading apex locator. You have to remember that the numbers that is on apex locator is not millimeters, nothing. And of course, I am checking again with my paper points. Actually, I'm still using my paper points if I am really right or is my apex locator right. So in that case, I don't have no instrumentation and no operation. So I know exactly where is should be stop on my apex locator scale when I have distracted 0.5 millimeters, a real 0.5 millimeters. Of course, there is some factors that can change and distort walking length measurements. So first of all is vital tissue inflammatory exudate, all the liquid is inside the canal. The most accurate readings is when the canal is dry. But the new generations of apex locator from 5th generation and 6th generation, they even can show for us accurate readings even the canal is wet. The canal shape, accumulation of dentin debris and calcification can affect accurate walking length determination. A lack of patency. I used to tell for my students, don't do measurement of walking length, or let's say on palatal, on distal canal, where the canals anatomically is very wide with number 8. If we don't have no calcification, nothing. Because the instrument should touch the dentin walls if you want to get the accurate readings. Of course, we can have an inaccurate readings and when we have an incompletely formed or closed apex. If we have inflammatory root resorption, when is it destroyed apical foramina or destroyed the apical constriction. And you can see that the accuracy is dropping when we have inflammatory root resorption. And what I like in the conclusion about this trial, that neither of the two apex locators were 100% accurate in determining the walking length. So electronic apex locator cannot replace radiographs, but will definitely serve as an effective adjuvant for our working length determination. Sometimes clinically we have situations when the apex locator's readings does not match with the image on the X-ray, and could be that our instrument or our gutta-perca is shorter, more than 3 millimeters, than the radiographic root apex. What it should be done in that cases, that I suggest you repeat the measurements with the apex locator and believe in apex locator readings, or according European Society of Endodontists, when you confirm again your apex locator readings, do another radiograph if the readings on apex locator will change. When the instrument is exactly at the radiographic root apex, so you have to again remember that in 50% of the cases, instrument is over anatomical apex. And of course, my suggestion, it could be that measure again with electronic apex locator and believe in its reading. And sometimes could be that the instrument is beyond the tip of radiographic root apex. So it means it's something wrong, because if you are beyond the apex, so you can have I told you, you have to use another methods like a paper point or something, so it could be blood bleeding, or so it's something wrong, and something wrong with you, not with apex locator, not with the X-ray. So conclusion, none of the technique, no electronic apex locator, no conventional digital radiography was totally satisfactory in establishing the true working length, because the true working length we can determine only after extraction. And putting some cutting slides of our canal and electronic light microscope to see the exact position of apical constriction. So as a clinicians, we are so limited in endodontology. We're so limited with diagnostic tools, even diagnostic tools for pulp vitality, diagnostic tools for walking length determination. So it's very important to put all the knowledges in one place, because there is no individual technique truly satisfactory in determining walking length. It's very important to write reading of radiographic images, right determination of the walking length with apex locator. That I want to remind you that if we have an error, it's usually operator error. It's usually your fault. So together with apex locator, together with radiographic images, use your tactile sensation, all but good, blood or tissue fluids on paper point. So please put all these 4 methods in one, just to be sure that you are not doing pop instrumentation. This is a statement from clinical meeting on European Society of Endodontology, and it's interesting. It's written that in process of working length determination, the main source of measurement error was the operator and the procedure itself. So this is nice. This is nice number from one study. They investigated approximately 500% of the root canal therapy, and the survival rate of endodontically treated teeth are high at 10 years after treatment, regardless of provider type, or general practitioners or endodontists. So, of molars treated by endodontists after 10 years have significantly higher survival rates than molars treated by non-endodontists. So again, the same picture, a picture of the same slide with what I started my presentation. And again, I have to ask myself, do I am satisfied with my endodontic treatment, with my obturation level here? Uh, Here I'm not satisfied. Here I'm not satisfied. Here too. There is two. So what I want to do, I want to change our concept of endodontic beauty. I want to change your thinking from radiology to biology. And even in some cases, when you can see that overfilling radiographically is minimal, so you can see that instrumentation is destroyed totally, completely apical constriction, and instrumentation it was done until apical foramina. And you can see some inflammation tissues around this filling material. But I have to be honest with you. So for me, the same. Even I know that this over instrumentation and obturation is not good. It is mysterious that countless overfilled cases don't fail and are successful over time. You can see in all these cases, I can say that everywhere is overfilled, but you can see that in all the cases, I had a healing of chronic apical periodontitis. I had a bone destruction healing. However, wrong is wrong. Even everyone is doing it. Right is right, even if no one is doing it. The last slide was good. I wanted you to read it, everything carefully. And thank you of being with me this 1 hour. And I think so this is a time for your questions.
Okay, Marvin, please show us the question.
Wow.
Oh, a lot of questions.
Uh, so let's start from the beginning. Hi, good evening, beneficial letter, welcome, hello from Ukraine, hold on. What is the distance between physiological apex and anatomical apex of the root? Actually, I wrote many numbers here. It could be from 0.2 until even 3.8 millimeters from anatomical apex. So the range is very high, it's very variable. And the exact position or exact the walking length knows only endodontist. And I hate that situation if somebody is doing endo treatment, used apex locator, tactile sensation, paper point techniques, everything, and going to have like say prosthodontic some procedures to put a crown, and the prosthodontist looking at the X-ray say, no, it's too short. I am getting mad about that it's too short. Maybe our apical constriction is like 4 millimeters from anatomical or radiographical apex. Only endodontist knows it. Only the person who did, or general practitioners who did endo treatment knows it because he used for working like determination all the methods to be sure. Yes, of course, in some cases when they have too short, more than 3 or 4 millimeters, and we have some rarefaction, of course, it means that instrumentation was not enough till apical constriction, and you have to do retreatment. What is the difference between apex and apical? I didn't catch a point of the question. This is a language things, This is not an endodontic thing. How to say? If we're talking about the root apex with some anatomical features, as I told you, we have a apical foramina or constriction major. We have a apical constriction or apex, yes, and we have radiographical apex. So the same, an apical limit, it means a limit until you're going for your instrumentation obturation. It should be until apical constriction, as I understood the question. Where should we stop in non-vital tooth at apex locator? I told you in all the cases, for me it doesn't matter the vital tooth or non-vital tooth. And usually I'm stopping 0.5 real millimeters from apical foramina, not the numbers in my apex locator. So I'm measuring exactly at the red bar. It means apical foramina. I'm destructing the 0.5 real my point. When it for me doesn't matter, but according to literature, in vital cases, it could be even more high. It's not so important. But in my point of view, in vital cases, we don't have to do endodontic treatment. This is about what I'm going to talk in Panendo conference in Egypt. So I'm not talking if we have a vital, let's say if we have inflammation of your leg on your hand, you're not cutting your leg or hand, yes? You're doing everything to remove inflammation until you not have an infection, until if you don't have a gangrene. Only after that you have to cut it. But inflammation is a treatable. You don't have to remove your leg or arms. Why we're removing the pulp tissues? It's only inflamed. Also another topic. Which is better to end the preparation of canals at the 0.00 or 0.5 millimeter cases of large apical lesions. Actually, there is no any 0 point. Let's start from this one. Anyway, if you have again 0.5 millimeters, it's you mean about readings on apex locator 0.5. So the 0.5, it doesn't mean 0.5 real millimeters. So lesions, I always do say, especially if you want to do obturation with it large for me big apical lesion is very big apical lesion when I have an apical size like number 80 or more than 80 until 80, because when we have an apical lesion, when we have a chronic apical periodontitis, we usually in most of the cases we have a inflamed root resorption. So the apical foramina or all apical limits are destroyed. So we have to create somehow this apical limit in the canal walls. And this is another topic. It's about the instrumentation, it's about irrigation protocols, it's about activation. I don't think so that in these cases the limited works the main reason how to heal or to for successful treatment. There's another things to do in endo if you want to have or you want to predict some good results. No. Dr. Mojek, no. Apical constriction is a histological point, even many times is not located historically. So called must end at No. Actually, one point of the question. Apical constriction is a histological point. Yes, I totally agree with it. Statement is a histological point of view. I told we cannot determine with any device, with any methods. We don't know. Only you can feel some cases by tactasis sensation, but these cases only when we don't have a reflection, when we don't have a chronic apical periodontitis. Of course, it can be detected only histologically after section under light microscope, but clinical we cannot determine. But anyway, I told you if we have a apex locator reading 0, 0, is not the apical constriction, apical foramina. And our apical foramina is not the limit of our instrumentation of. We have to not go until exactly apical foramina. We can have a little bit like 0, not the limit of apical foramina. So if you do instrumentation then 0, 0 on your apex locator readings, so you will do instrumentation in exactly at the apical foramina. This is not a limit. It's not any biological consideration about this instrumentation. I told you why there is still debate about these limits. But it's even more than 100 years ago it was written this could be stopped on apical constriction. So it should be above the apical foramina level. What is the percentage of failure of endo treatment because of lateral canals and apical third? Actually, it's a very good question. This is I like it. Maybe it could win a prize.
Nominated already.
That is a two opinion about the feeling of lateral canals. Uh, Usually, you can feel a lateral canals if the lateral canals are very wide. If the canals are very narrow, usually you're not cleaning. And after histological examination, usually it's a mess between necrotic vital pulp tissues in a sealer inside. They're not clean. So thinking that you have to clean apical ramification on accessory canals, there is no any methods to do it. It's only by chance if you had a very wide these lateral canals, you can feel it if you're doing your obturation, especially with resin-based sealer like AH+. If you will use like hydraulic calcium silicate sealer, I never got in my life the feeling of laterals, obturation of lateral canals because it's not soluble, it's not going inside the small accessory canals. And I suggest you to read some works of Dr. Domenico Ricucci from Italy. He's very famous of his histological examination, and especially he had a topic about how to fill arterial canals, or it should be filled or something, because he did many cut slides of the apical part of the root, and he investigated that these lateral canals are not clean and just it's like mess, total mess, and it's full of tissues and degraded tissues and filled with some pieces of sealer. So I don't think go for endodontic treatment, it should be lateral canals or accessory canals. We have to do disinfection as much as possible because we don't have any methods for sterilization of the canal. We're just doing disinfection. There's no 100% that will not let the bacteria to have a survival. It's only like reduce bacterial amount and block them into. That's all. What we can do as endodontists, we cannot go inside. And as told you, we're limited with diagnostic tools, with methods, with materials. Good question. Thank you. If we don't have tuck back, is that right to use bioceramic sealer? Wow, the same good question. I think so. The tech bag, it's obligatory to have when you're doing lateral condensation or when you're doing vertical condensation, because the main material when you're doing with normal sealer gutta percha is gutta percha. It's a sealer. You have to have a small amount of a sealer, and the main material in the canal for obturation is only gutta percha. In when you're doing obturation of bioceramic, the most important material is a sealer, and your point, gutta percha point, is only a carrier to insert this sealer into the canal. Actually, yes, it's not so important to have a step back because it's very important, especially with the sealer to close your apical part. But again, it's topic for another lecture, and I'm not sure, but logically, if I'm thinking, maybe it could be like you don't need to have a tech back, but I have to read it. Sorry, the obturation is not the point when I'm interesting actually, but very good question, very good question. Thank you. What is the best technical tool? I think so. Is it not tool determine the root apex radiographic or apex locator or both together is more believed? Oh, I told you. Of course, you have to use an apex locator and this radiographic images, but I'm always trusting my apex locator because foramina. But with apex locator, electronic apex locator, at least exact position of apical foramina. And on X-ray, periapical X-ray, we cannot see even the place where the apical foramen exists. So usually, if we have some doubts to trust apex locator or to trust radiographic images, I would trust apex locator. In open apex cases, if we do apexogenesis, could we have apical constriction that would make tag back? No, 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 no. Of course, in open apex cases, we don't have no apical foramina, no apical constriction, nothing. And if we're doing apexogenesis, we don't have to have a tag back because we have a genesis. We are not doing obturation. We're just because there is two main treatment methods: apexogenesis and apexofication. In apexofication cases, we're doing obturation on apical part with some hydraulic bioceramic materials, and in apexogenesis, we are just letting like regeneration procedures to regenerate some tissues inside the canal. It's not about tissues, it's just some kind of vital tissues, so maybe some fiber tissues. There's nothing about the tech back. No, in open apex cases, there is nothing about tech back. Or we're doing apexogenesis when we're doing a vital pulse therapy, or we're doing apexofication with MTA. It's nothing about tech back. What is the maximum of file for preparation the apical and preserve the apical constriction in the same time? Wow, it's a good question. It's a good question, and it's still debates on how big preparation should be. I think so. It's the same. It depends on every clinical case. It depends on every clinical case. There is some studies done about anatomical size of the apices on all the teeth. I think so. You can find on internet now very easily the table that is let's say when we're talking about the front incisor, or we're talking about the molar palate, or we're talking about the smaller distal root, instrumentation of to rate with number 25. It could be Can you hear me?
It was cut for seconds, and now I can hear you well.
Okay, so if we're talking about the lower incisors, it's the same. It's you cannot do preparation for lower incisors with two canals until number 55, 30, or 35. There is no one rule. Of course, I think so. You have to be um, practical, and you have to be practical as much as you can be, but think how to clean, because instrumentation of a canal is not only shaping of a canal to create a shape, but you have to mechanically clean a dentin wall, infected dental wall. So the same, you have to clean it, but you still need to keep it this canal as close to anatomical morphology what it was before treatment. In this case, we have to talk about some instruments. Let's say the same. This is my. Oh, I have a lecture about the instrumentation. So, in my point of view, we have to talk about some expanding instruments when we're leaving our canal morphology in that is previous, what it was before treatment. Just enlarge what is more canal wider, and whereas the canal is smaller, not to enlarge too much. So actually, this is yeah, this is I think so. It can be said in one word. Avoid. Don't do instrumentation over instrumentation, of course, or to destroy apical constriction, apical foramina. So many dentists who want to do instrumentation until 0, 0, or apical foramina, of course, they're doing over preparation. I think so in that case. When we have apical constriction, this is some limits for you. And this is limits depends on the first instrument which is binds into your canal. Everything is clear. What the first irrigation to start with the first file? Okay, it's another topic. It's about irrigation. That is, I like it. This is my topic about irrigation. I'm a fan of irrigation. I'm not fine too much about instrumentation, but I'm fond of irrigation. It depends. Doing conformating, or you are working with rotary instruments, or you're working with manual instruments. And again, this is because my point of view is totally different than the this opinion or everywhere in the world, because in my point of view, as I'm using like dual rinse technique, what I have at the same syringe and etidronic chelating agent and sodium hypochlorite. But again, if you are using the conventional protocol, that in the beginning you are using the sodium hypochlorite, only at the end, before obturation or before putting a calcium hydroxide, you are using very activated sodium hypochlorite, and at that, ADTA. I don't like this protocol. I don't want to agree with it, because all the time when you're working with the instruments, what you are doing, you are creating a smear layer. Yes, because what is a smear layer? Is it grease? Is the grease? Is bacteria? Is necrotic tissue? Time when you are working with instrument, you are creating this smear layer, and every time the smear layer is thicker, thicker, and thicker, and you're rinsing with sodium hypochlorite, but you are closing everything with your closing your dental tubules, you are closing your accessory canals, and you still want that your sodium hypochlorite do a work, will still work. How it? And only after that, when you are finishing your instrumentation, okay, you're opening these dental tubules, you are opening these accessory canals with your etidronic acid. And of course, in that case, you have to put a calcium hydroxide or some disinfection material into the canal, because all the time when you use sodium hypochlorite, you just created a smear layer, just closed all your dentin with a smear layer. So I I'm totally different thinking than others. I told you I'm a very extraordinary person. So in my point of view, it should be different. In the all the instrumentation period, you have to use chelating agent to remove the smear layer. And only after that, when it's removed, when your dental tube is open, you have to put a sodium hypochlorite. It depends the same on which cases. If we have a vital cases, I told you in vital cases, I don't want to do pulpectomy. I prefer to do pulpotomy just to preserve the vital tissues. So in that case, maybe you need a sodium hypochlorite if you're all thinking dentist, just to dissolve the tissues because it's only one material and only one solution that can dissolve the vital or necrotic tissues. But if you have a let's say necrotic case that is a canal empty or treatment cases, of course we have to start from the EDTA because especially in treatment cases. Because in treatment cases, the EDTA dissolving many kinds of sealers. So your treatment case in that easy. Sorry, I cannot answer in couple of minutes about this. I told you this is a very, very interesting topic, and I told that I am using dual rinse technique, a special, only one acid that could be used together with sodium hypochlorite. I cannot change the features of sodium hypochlorite. It's only one material in the world. It's etidronic acid. You can read it. Some studies from Zurich University, from Switzerland, from Professor Matthias Zender. What should we do if we have internal resorption? We lost the apical constriction. No, yeah, in internal resorption, we don't care too much about apical constriction. We care more about how to clean the lagoons of apical resorption. So anyway, in the apical internal resorption, anyway, we're doing obturation calcium silicate cement. So we don't care too much about apical constriction. In that case, it's usually the apical size is very, very big. It's very wide. Mm, um, how far from the apex should root and resection be done? Oh my gosh, it's about surgery question. The same, it depends on the case. It depends on the clinical case. It depends on how your canal is obturated. If it's obturated at the before apicosectomy, so you're doing apicosectomy according to your lesion size. There is no one answer. We have to talk about the same. It's a big ledger. It's not one answer. It's not like 2-3 millimeters. It's usually resection done is more about retrogradic instrumentation of the canal, how deep it should be done. So at least minimum 3 millimeters, it should be done retrogradic instrumentation of the canal. Sometimes it is difficult to convince the patient that the canal is sealed correctly. How to act in this case? So don't convince. Easy. Why you have to convince? Don't convince it. If the patient always his doctor to choose the not convincing any patient. It's not my job. My job to do endodontic treatment. My job to seek a successful endodontic treatment. That's all. I'm not in my clinic to convince a patient that is still correctly. As a patient or believes you or not believe you. It's about you. It's about your personality, about your knowledge. It's about your possibility to explain normal words to the patient because you have to talk in their language, yeah, not the dentist language. They have to understand you. I think so. I think so. It's all the questions. There's no more questions on my phone.
Okay, now you have to choose one to win the first prize. So, what do you think? What is the best question?
Okay. Let me back to these two questions. No. Yeah, I think so. What is it? Where is this question? Where is this question? I thought about this lateral canals. Yes, it was. I think so. I mentioned about this is center preparation post large apical lesion. Mm, I can't to find this about lateral canals. It was about lateral canals. Oh, and I can't find the doctor who wrote me about the lateral canals. It should be obturacious. I want to predict the treatment results.
Wait
Can
one
you
second.
help me, Mr. Ahmed?
Okay, I will open it now. Please, Marvin, show us again quickly the comments.
Oh, he wrote me. His name is Bashar Migdad.
Dr. Bashar Mekdad. Okay,
Dr. Bashar Migdad.
congratulations.
Yeah.
Okay,
Uh,
Dr.
thank
Bashar,
you. Thank you,
congratulations.
Doctor.
You have won with us
Question.
three sets
So
of
I think so. Yeah.
SC Pro rotary files. You're so lucky, and we are grateful for sure for Dr. Zivir for picking your question. Okay, and now it's okay, and I would like to thank Dr. Zivil for your wonderful lecture. I hope our dentists have learned a lot from your lecture, as we would like to thank you again. And please don't forget to fill in the form for the certificate. And I think that's all for today. Thank you again, Dr. Zivil, and nice to
Yeah.
meet you again.
And I want to invite all my Egyptian friends to visit Panendo this year after in 1 month in the first week of July, and I'll talk more interestedly. What is I'm passionate about it is the vital talk therapy.
Of course, we are all waiting for this great event. Okay, it will be
Thank
on
you.
6th of July. Thank you.
Yeah.
Okay, see you
Thank
there.
you, everybody. Have a good evening. Bye bye.
Okay, okay. Bye bye. Okay, thank you.
Thank you.